However, excisional biopsy may be indicated in some lesions. For example, if you have nevus and you think that this is probably melanoma, you can take a biopsy, okay, remove the whole tumor with 1 to 2 millimeter margin around, and if it is benign, this will end good. If it is malignant, you can go and have further X-ray. The biopsy, there are some important things, yeah, that the surgeon is responsible about the selection of appropriate biopsy method and site. Okay, so that it is very important that to decide where is the from where you take the biopsy to be sure that you took the tissue that you need, and they are responsible to send this to the pathologist at the proper time and the proper situation, okay, in the environment, okay. Don't leave it to dry, don't make it too late, don't label it wrongly, and so on. And you have to have an idea to receive the, or a method to receive the results of the biopsy. Very important, not only to take the biopsy, but to know about the results of the biopsy. And this will be delivered to the patient or to other physicians or to the family. And sometimes the surgeon give an idea about the prognosis and the line of the treatment after knowing the pathology results. Also, the surgeon, he should, as we said, orient the specimen, ensure integrity of the tissue planes, and I will show you a picture, and ensure the adequacy of tissue sample. Sometimes they said that this is not adequate, or it is just minimal cells that we cannot pass judgment, and so on. And be sure that the tissue that you take is sended to the pathology department, not discarded or dismissed by anybody. For example, if you see that the upper photo here, that this is a white local excision. We mean that there is a tumor inside that specimen, and usually we took some skin because the skin is near to the tumor, and it is labeled. For example, this is the medial side, this is the upper, and this is the lower, this is the lateral side, this is the superficial side where the skin is deep, and opposite to the skin, a deep side, so that the pathologist required to examine in 6 dimensions the biopsy in order to say that the margins are free or involved. Also, when we take a biopsy from an ulcer, it should come from the edge of the ulcer here, not from the center, because in this area, usually there are necrotic material and necrotic tissue. But we take the biopsy from the edge, which gives you an idea about the normal disease, the edge where the transition from benign to malignant, and going to the core of the biopsy. So that taking a biopsy from the center of the tumor is not a good idea. Also, in patients having soft tissue sarcoma, especially in the extremities, as you see that you have to do your incision parallel to the longitudinal axis of the limb, okay? Because if sometimes you find that the people make a transverse incision, when you need to treat this patient, you have to take this scar with you, so that if you imagine that it is in a horizontal line, you have to remove a big piece of skin which require reconstruction and complicate the procedure. So that all the time it should be precise, direct, over the tumor in longitudinal axis, and don't do dissection, so that your incision will go direct from the skin towards the tumor. Those are very important principles you have to adopt in your career in order not to cause morbidity to the people and to have a proper orientation. Now, the surgical management of cancer. What are the objectives? Our objective is to cure the patient. And usually cure is a difficult task in advanced stage. And if we cannot cure the patient, we can do some sort of palliation. And the palliation is very important. Don't think that the palliation is something not good, okay? Suppose that if the patient is going to live for 2 to 3 months with good life, okay, it's much better than to live these 2 months in agony, okay? So that palliation is very important to be accepted line of treatment for the surgical oncologist and for the patient and the family. We can say you cannot add years to the life. We can add life to the remaining years or to the remaining time, okay? But to have a remaining life in agony, in misery, patients having bleeding, ulcerations, like that patient you see who's having this ulcer in the face, so that this patient, he is socially, if you don't do anything for him, he is socially dead. He cannot see the people, he cannot talk probably, he cannot see, he cannot breathe. There is a smell, there is ooze, there is ulcerations. Some of the insects, like mosquito, they will come to this region, they lay down their larvae, and it comes like a worm from the wound. It's a very terrible situation. Okay. Now, surgery is very important, as we said, in many aspects. It is the cornerstone for the treatment. And one of the examples is melanoma. If a patient having melanoma, and this is early, and you remove it with an adequate safety margin, the survival is very high, and you don't need any further treatment. And now the surgical capability are increasing with the presence of reconstruction. So that those are the examples. Local resection, for example, patient having basal cell carcinoma, we take 2 to 3 millimeter around. This is called local resection. Wide resection, we take a wider margin, at least 1 centimeter around the tumor. We have what's called radical local excision. For example, a patient having soft tissue sarcoma in the posterior compartment of the leg, you remove the whole compartment. This is considered to be wide local excision. And there is a term in block excision, where you remove the primary tumor with the surrounding lymphatics around. Surgical resection of the tumor, adequate margin of the resection, the prevention of the tumor spillage. One of the examples is that when you operate on the kidney, don't all the time just try to make pressure on the kidney, because sometimes the malignant tissue at the time of making the pressure during surgery, some of the malignant tissue will migrate or extravasate down to the inferior vena cava and causing malignant thrombosis. Also, there is what is called in the past no-touch technique, that you don't all the time hold the tumor in your hand in the colon. It may lead to transmural spread, and this may facilitate recurrence. And minimal manipulation, don't all the time try to stimulate the tumor cells by squeezing with your hand. And also, we need, after removal of the tumor, to think about the reconstruction. For example, this patient having recurrent soft tissue sarcoma in the anterior wall, in the pectoral wall, the only adequate surgery to be done is to have a full thickness excision down to the line. Okay? So that is more than radical than one imagine, that you remove 3 reps, you remove the tumor, you remove everything. We cannot do this unless we can do sometimes, زي ما حكينا إنه if we cannot deal with the tumor, for example, patient having intestinal obstruction due to colon cancer at the rectus sigmoid, and this infiltrates all the surrounding tissues, but the patient is obstructed. So that one of the options is to relieve this obstruction by doing colostomy. People sometimes they have esophageal malignancy and are unable to eat. So probably doing gastrostomy for feeding, this will change their life. Also, if a patient having malignancy in the leg, distal leg, with intractable pain, infection, probably amputation for palliation, and putting a useful, making a useful stump and putting an artificial prosthesis will change the lifestyle of this patient. Surgery is extended to remove a residual disease. What do we mean by a residual disease? Nowadays we use a new adjuvant chemotherapy or upfront chemotherapy. We take from a patient having a locally advanced breast cancer, we take a true-cut biopsy, they said that this is malignant. We cannot operate on those patients for technical reasons, so that we may start giving them chemotherapy, so that this will shrink, reduce the tumor, probably control the distant metastasis, and after a few courses, there will be a residual disease. We will go and remove that disease from the breast. Also, sometimes patients having treatment by radiotherapy. Example, floor of the mouth tumor or tumors of the tongue. The patients from the start don't like to do the surgery or refuse the surgery. They go to the radiotherapy, and after taking the radiotherapy, still there is a residual disease. You will go and excise this residual disease. Also, after inadequate surgery, if you do wide local excision and the margins coming positive, so that you have to do further surgery for the residual disease. Also, the cytoreduction, as we said, that removal part of the tumor without other treatment by chemo and radiotherapy, probably this will invite flare of the tumor and recurrence of the tumor. So that one of the concepts, when you have a big bulky tumor, I gave you the example of Burkitt lymphoma before, that you remove the major bulk of this tumor and then you start chemotherapy. Probably the chemotherapy dose will be less, it will be more effective, and you will prevent the burden of the tumor lysis syndrome. You know that when the cells are responding, they will be killed, so that the contents of the cell will be go to the circulation, and this probably will cause sort of renal failure. If we have patients having a locally advanced ovarian cancer, having multiple masses, and you operate on those people doing the primary treatment, which is hysterectomy, salpingo-ovarectomy, and omentectomy, and you leave multiple residual small tumors in the abdominal cavity. If you remove these tumors and you reduce their size to 1 centimeter, those will respond very well to the chemotherapy, and by this technique, usually there is an improvement in the survival of those patients with ovarian cancer. Also, one of the concepts is resection of metastatic disease. Okay, metastases usually, as we said, go to the lung, to the brain, to the liver, and to the bone. And there are several attempts in certain tumors that removal of metastasis giving a good survival advantage. For example, if the primary tumor is controlled and the metastasis occurring after a long period from treatment of local primary, if the tumor is either single or multiple but within a segment, and you are amenable to resect those tumors with safety margin. And it's one of the concepts that the tumor doubling time, which we said about before. So that if the tumor doubling time is very rapid, probably doing metastatectomy will not be a reasonable option. But if the doubling time is prolonged, probably this will benefit the people. Those are attempts in case of colon cancer, and when the primary tumor is controlled, and there is a 1 or 2 or 3 liver metastases, and those are resected, this gives a survival of the people, 40%, 5-year survival. Removal of metastatic sarcoma to the lung, okay? This gives 5-year survival of 30%, which is actually much better than a treatment of a primary lung cancer, okay? So that brain metastasis give a survival advantage to the people. Okay, we will stop today. We can